This topic is hyperkalemia. Hyperkalemia refers to a high serum potassium level. And to better understand hyperkalemia, let's first revisit potassium's role within the body. Potassium is a major intracellular ion, and it helps to maintain the intracellular fluid volume. Potassium and sodium are exchanged for one another across the cell membrane, with higher concentrations of potassium inside the cell and higher concentrations of sodium outside of the cell. The difference in the concentrations between these two electrolytes helps to establish an action potential across the cell membrane. And this exchange of sodium and potassium is very important when it comes to influencing muscle contractility, especially within the heart muscles, skeletal muscles, and smooth muscles found within the gastrointestinal tract. With hyperkalemia, there is an abnormally high level of potassium within the blood, which is any level that is greater than 5 milliequivalents per liter or 5 millimoles per liter. This high level of potassium can lead to a number of different complications. We primarily receive potassium through our diet, store that potassium within cells throughout the body, and eventually excrete potassium through the renal system. If any one of those processes is affected, however, this can lead to the development of hyperkalemia. For instance, hyperkalemia may develop from a large intake of potassium, either through oral supplements or overcorrection of hypokalemia from IV potassium administration. Hyperkalemia may also develop from reduced renal excretion of potassium, which occurs in such instances as acute or chronic kidney disease, taking potassium-sparing diuretics such as spironolactone, or if the client has reduced aldosterone secretion, which can occur if they are taking ACE inhibitors or if they have Addison disease. Certain conditions may cause a sudden release of potassium from the body's cells and includes metabolic acidosis brought on by diabetic ketoacidosis. Potassium ions have a direct relationship with hydrogen ions in the body, and hydrogen ions are considered to be acidic. Therefore, when we have acidosis develop in the body and this increased concentration of hydrogen ions, we can also anticipate a gain of potassium ions within the blood. Insulin deficiency and hyperglycemia can also precipitate hyperkalemia. Insulin is needed to not only bring glucose into the cells, but during that process, potassium is also brought into the cells. Therefore, if we are lacking insulin in the body, this can also lead to a buildup of potassium within the blood. Any condition that disrupts the cell membrane or destroys the cell can also contribute to the release of intracellular potassium. These conditions include muscle injury in the form of rhabdomyolysis and tumor lysis syndrome. One thing that we should be aware of when it comes to drawing potassium levels is the presence of pseudo-hyperkalemia. This is a falsely high potassium level that occurs after a blood sample is drawn. During the process of drawing blood, storing blood, and transporting blood, the red blood cells themselves may rupture, and the potassium that they contain can lead to excessive levels of potassium inside the sample itself. Therefore, it's important that we make sure to maintain proper techniques when drawing blood, storing that blood, and transporting it. Abnormal levels of potassium within the body can lead to the development of certain cardiac dysrhythmias, some of which are life-threatening. Therefore, our first priority should be to monitor the client's heart rate and rhythm, and we can do this by obtaining an initial electrocardiogram as well as continuing cardiac monitoring throughout the client's stay. Certain initial changes on electrocardiogram that we should be aware of are the development of tall-peaked T waves and the absence of a P wave. With hyperkalemia, the client is more likely to develop problems with cardiac conduction, resulting in heart block. Additionally, ascending muscle weakness can occur, which starts in the legs and the lower body and works its way up towards the trunk and the arms. This can lead to paralysis, and this overall pattern of ascending muscle weakness is very similar to what we see in Guillain-Barré syndrome. Complications include the development of life-threatening cardiac dysrhythmias, such as ventricular fibrillation and asystole. The higher the level of potassium and the longer that the client has had hyperkalemia, the more likely it is that they have or will develop cardiac dysrhythmias. This image here shows the different electrocardiogram changes that can occur for a client who has hyperkalemia, with panel 1 showing initial changes, such as a prolonged PR interval and tall peaked T waves. Panel 2 shows a progression of the cardiac changes that can occur with hyperkalemia, with the loss of a P wave and ST segment depression. If hyperkalemia is severe or left untreated, this can lead to panel 3 and panel 4, which is widening of the QRS complex until the client eventually develops cardiac asystole. When treating abnormal potassium levels, we need to make sure that we are monitoring serum electrolyte levels all throughout treatment. This way, we can make sure that we are providing appropriate treatment and not overcorrecting high potassium levels. As I said before, continuous cardiac monitoring should be initiated and maintained during treatment, and we should utilize interventions to promote potassium excretion. If the client has appropriate kidney function, we can administer potassium-wasting diuretics, such as furosemide, to promote renal excretion of potassium. Oral potassium binders, such as patiromer and sodium polystyrene sulfonate, can be administered to sequester potassium within the gastrointestinal tract, as well as draw out potassium from the body to be eliminated through the stool. If the client does have significant renal impairment, they may need hemodialysis to remove that potassium from the body. We may need to administer medications to help drive potassium into the cells and out of the blood. Remember, I mentioned that insulin drives not only glucose, but also potassium into the cells. Therefore, we can administer regular insulin intravenously to help reduce serum potassium levels. However, we need to be very cautious about this, as this can cause the client to become hypoglycemic. Therefore, we can also administer IV dextrose at the same time as we administer IV regular insulin, which will help to maintain serum glucose levels, but bring that potassium into the cells. Additionally, beta-adrenergic agonists, such as albuterol, also help to drive potassium into the cells. This medication may not be as effective as the insulin administration, as we would have to administer multiple doses of that albuterol in order to begin seeing an effect on the potassium levels in the body. If we notice any electrocardiogram changes, it may be necessary for us to administer medications to stabilize myocardial cell membranes. IV calcium gluconate can be administered to help balance the resting membrane potential. Lastly, we should encourage the client to avoid foods that are high in potassium. And we can think of high potassium foods by remembering the mnemonic, fast bunny can carry many oranges, roast potatoes, pork, and beef. The word fast stands for fish, avocado, spinach, strawberries, and tomatoes. The phrase bunny can carry many oranges stands for bananas, cantaloupe, carrots, mushrooms, and oranges. And roast potatoes, pork, and beef stands for raisins, potatoes, pork, and beef.